It's a normal clinic afternoon. You have a day full of patients already, but a patient calls with utter panic in her voice for an emergent add-on appointment. The only information you have is that she's here for a rash. She's a 25-year-old female with a past medical history of bipolar disorder, polysubstance use disorder, presumed seronegative rheumatoid arthritis. You enter the room and she has diffuse, widespread pustules with an erythematous background. She has several larger patches with scales, no mucosal involvement. Around her ankles, she has what looks to be ruptured superficial abscesses with purulent drainage. She states that she has been on adalimumab therapy for around 10 months, but her dose was just increased. A few days earlier, she had been given a course of oral prednisone. Seemingly, her rash had spread from her extremities to her trunk overnight. This was thought to be an underlying psoriatic arthritis that was misdiagnosed with seronegative rheumatoid arthritis, since her arthralgias were so profound and presented before a widespread rash.
Therefore, her adalimumab and prednisone therapy were stopped. A prompt biopsy was obtained, and she was started on cephalexin, hydroxyzine, tacrolimus cream, and triamcinolone cream. Her biopsy came back consistent with psoriasis.
The course was extremely complicated and involved two different hospital stays. She was started on a number of biological agents, with none showing amazing response. However, her rash was never as severe after she stopped the adalimumab therapy, which is paradoxical given the medicine can both treat and be the underlying etiology of the disease. The main emphasis of her case is that systemic steroids can exacerbate psoriatic arthritis and cause generalized pustular psoriasis that our patient presented with. In fact, 95% of cases of acute generalized pustular psoriasis and almost 50% of generalized pustular psoriasis have systemic steroids as the onsetting agent. By identifying high-risk features such as fevers, significant myalgias, and lab findings such as leukocytosis greater than 30,000, high ESR, lymphopenia, elevated liver enzymes, and major electrolyte abnormalities, it helps you triage these patients and identify the ones that need prompt hospitalization. Though we should rely on our dermatology and rheumatology colleagues for the majority of biological agents, it's good to have a basic understanding of the treatment options. For non-disabling disease or maintenance therapy, we depend on acitretin and methotrexate with obvious avoidance of use during pregnancy or planned pregnancy. For severe disease, being able to initiate cyclosporin or infliximab or a whole host of biological alternatives. Adjunct therapy can include phototherapy, which can be difficult given days to weeks to see improvement. Topical treatments with corticosteroids, vitamin D analogs, tacrolimus creams, or ointments are useful but impractical given the extent of the rash. As long as we, as general internists, are familiar with generalized pustular psoriasis and the exacerbating factors, it can greatly help triage and effectively treat these patients.